the real patient population, the morbidly obese, not going to change their diet. What are your thoughts on does it achieve anything?
Yeah, I think I've kind of covered that in my slides actually. Hopefully.
The real question is there a benefit in the private sector to the NHS? Does it offer any difference to patients? Who's going to do the countdown already?
So Ollie's not back in yet.
What's the mobile phones off?
Ollie's first, I think.
He's first, but he's not on the line yet. He's trying to
We've got
log
a
in.
few minutes live, right here.
Should we get him to email us, talk in if we can't?
But you'll have yours can launch and you can play it.
Yeah, I've just done a quick test. It seemed to be okay.
In terms of shot, they're going to pull directly at the camera.
Yeah.
So I'll keep it wide and then zoom in.
Yeah, absolutely. Yeah, nice creepy. Yeah, yeah.
Pan across.
Yeah.
It's just spare it. Just
Keep the attention. Yeah, keep it.
Yes. Yeah. Is the camera at the right angle? Am I looking in the right place?
Yeah.
Just there. Correct.
This one doesn't help you. It looks like it's.
Yeah. Is that a bit wonky?
Yeah.
What's the first?
We're bubble.
What's the first?
Yeah, we're
Yeah,
that's fine there.
That will go on. First talk is not on there. They're going to share screens.
Yeah, but what's the first one we do?
The first one we do is this afternoon. I don't know if
Could-
this one will be mine.
Could the administrator? Let me let Ollie in. There we go. There you are.
Hi.
Hi,
Do you want to try sharing?
I will if that's all right. Excellent. I think we're much better. Yeah, I mean the app's much better actually. That's the issue.
Okay.
You can see that?
Yeah.
It's going to be all right. Speakers.
Yes, we can. Yeah.
Yeah.
I can see your whole screen at the moment.
Yeah.
It's going
Okay.
to be all right with this.
Fantastic, yeah.
We're going to be two-way talking like fun.
What have we got? My watch says another 2 minutes.
Yeah, I think mine says 32, so we're probably.
Okay, we're over. Okay.
Yeah.
Are you happy on camera?
Yes, absolutely.
You want a photograph of Twitter? Yeah.
I'll get one quickly.
What to do it if it's
Okay. I'll put one on here first.
Do you want to count us in then?
Am I recording this?
Not yet.
Just waiting for your countdown, guys.
There's a lot of kits here. They're BBC Pros.
Okay,
Right.
You ready?
Do you count us in and give me the nod.
Ed, you going to count us
Count
on?
us in. 3, 2, 1.
3, 2, 1.
Well, good morning. Welcome to the ICENI Centre here in Colchester and our first online renal stone training day. My name's Stephen Kieran. I'm a urology consultant. On my right is my friend and colleague Zaf Mann, who's another endo urologist. Firstly, thank you to our sponsors, Boston Scientific and Wolf, who funded the IT and camera crew today. We're aware lots of people have logged in from abroad. We are a pair of 2 average-sized district general hospitals, about an hour and a half north of London. And between us, we look after just under 1 million population. We are lucky enough or unlucky enough to look after the most socially deprived part of England, officially the most socially deprived, which has a vast amount of diabetes, hypertension, smoking, comorbidity, and therefore, of course, stone disease in highly comorbid patients. In the east of England, it is also warm and very dry, which I think does contribute to our stone disease as well. A little bit of housekeeping. We've switched your cameras and your microphones off, and the chat line won't be monitored this morning because our schedule is very tight. We will probably have a look at that this afternoon. So I'm going to go straight into our first 2 speakers. I've twisted the arm of 2 friends and colleagues to come and talk to us. Ben Turney, I was driving home last night and realised I've known him for 20 years and thought, how did that happen? And Ollie Wiseman, who I've got to know well since I moved to East Anglia, are going to go head to head in an Oxford-Cambridge debate on the benefit of metabolic stone screening. So good morning, guys. I'll hand it over to you.
Hi, good morning, Stephen. Thanks very much for the invitation. Good morning, everyone. Hello again, Ben. I'm very much looking forward to the next 45 minutes or so, where we can talk through some of the pros and cons of metabolic screening. So as Stephen says, I'm Oliver Wiseman. I'm a consultant in Cambridge in the UK, and I am going to talk about the benefits, in my view, of metabolic evaluation of recurrent stone formers, and try and show you that I think it's both clinically and financially indicated. Here are my conflicts of interest. The only ones which are relevant really is that together with Ben, we have set up a service which offers screening and advice to patients who have recurrent stones. And also from the education point of view, I also have done some work with DeviCare. So I'm going to tell you why I think that we should be offering this to a significant proportion of our patients. And as Stephen said, this is a head-to-head debate of Oxford against Cambridge. And I'm sure that you can see from this boat race picture, Cambridge are well in the lead. And that's where I hope to stay for the next 45 minutes or so. So if we look at the EU guidelines, I think that most of us would agree that for the low-risk stone former, some basic tests are probably all that's needed. And from the advice point of view, some general preventative measures. And so for the sake of the next few minutes, I want to just park that, and I'm sure that we can all agree on that. And I want to then move to focus on the EU guidelines for the high-risk stone formers. So the EU guidelines would say that for the high-risk stone formers, we need to offer more specific advice. But the kind of generic advice that we would offer to everybody else is, you know, have more fluid, maybe try and veganize your diet a bit to have more fruit and veg, have a normal calcium intake, try and cut back on your salt intake, and together with increasing your veg and fiber, cut back on your animal protein. But when we look at the high-risk stone former, we need to get a little bit more specific, and we need to think about who we might do that on, how we might do it, and then also to discuss what actually is that added benefit to try and prevent recurrent stone disease. So the high-risk patients can be split up into lots of different groups, but essentially these are patients who have highly recurrent stone disease. Some definitions would say more than 3 stones in 3 years. They're children or patients who have their first stone under 30, patients who've had treatment who have residual stone fragments, patients who have nephrocalcinosis or a family history. And then if you look more specifically at stone types, they're patients who've got infection, uric acid, cystine or brushite stones, those with specific comorbidities, which include hyperparathyroidism or GI diseases. And then those patients who've got anatomical abnormalities, which are going to make them more at risk if they get stones, or less likely to be able to clear stones or stone fragments should they develop them. And what always strikes me is looking at this list is that you think actually these are most of the patients, you know, most of the patients that I see in my stone clinic would meet one of these criteria. This is the list from the EAU, and it's, you know, very similar. It's just split up into slightly different subcategories. So I'm really going to focus now on these high-risk patients. So the question is really metabolic screening. Why should we do it, and is it useful? And this study here was done and published by Lotan, and they looked and they showed that if you look at the recurrence based on intervention, whether you just give generic advice, which was the placebo group, or you recommend specific dietary changes, or you introduce metabolic therapy, the risk of recurrence of stone decreases as you get an increasing intervention going from 26 stone recurrences per 100 person years for the placebo group down to 9 per 100 person years for the medical therapy group. And this other study by Ferraro has shown that this intervention is cost effective. For first-time stone formers, actually conservative therapy is the most cost effective and efficacious. But for these recurrent stone formers that I've been talking about, medical therapy significantly reduces recurrence and is cost effective. The effect of that targeted therapy is only beneficial in patients who've had more than 2 stone episodes. This study is a very well-known study by Fine et al., who looked at patients who had had lithotripsy. There were 80 patients, and they looked at the patients who were stone-free or who had residual stones, and then looked at the chance of them developing stones again over time, according to whether they had no medical therapy, which is the yellow bars, or they had medical therapy, which is the pink bars. And you can see that the patients who had specific medical therapy had a significant reduction in stone recurrence rates when looked at stones per patient per year. That's in both those who were stone-free after lithotripsy and those who had residual stones. And then this multi-center RCT by Kokvara et al. Looked at the effectiveness of specific non-medical prophylaxis and non-specific dietary prophylaxis in patients who had their first idiopathic calcium stone. So there were 240 patients who were split up into 2 groups: the intervention group, who had quite comprehensive screening, and the control group, who had just minimal metabolic screening. And then, based upon the findings from those investigations, specific dietary advice was then given to those patients in the intervention arm, who had the more investigations done. And then when you look at 3 years at each of these 3 centres, you can see that recurrent stones were seen in 2/3 less of patients in those who were significantly investigated compared to the control group. So more evidence that detailed screening and bespoke advice does indeed reduce recurrence rates. I think we have to think about, when we're doing metabolic management, why we're doing it. So we're doing it to try and identify a particular risk factor of stone formation in the patient concerned, and also to reduce the supersaturation of urine with respect to the stone forming mineral concerned. And that's to stop new formation of stones and also to decrease the growth in residual fragments. I don't really want to pretend, though, that doing this more comprehensive medical management is easy, because it's really not. It's very difficult to treat stone patients satisfactorily without proper biochemical screening, and as I say, or as we'll see, this is generally poorly done. Most stone patients, though, feel well most of the time, and it's quite hard to convince them that they're going to maintain the changes which you've suggested when they may be 5 years out of their stone episode. So unfortunately, we don't also have the resources to bring them back for that stone clinic effect, to remind them of the benefits of continuing on with their medical management. But when you look at how frequently we're investigating these patients, you can see that of the high-risk stone-forming group that we've talked about in a big study in the States, only actually 7.4% underwent a 24-hour urine evaluation. Patient compliance with this workup is also poor. So in a single centre retrospective chart review of 193 patients, only 42.5% of those patients who were asked to submitted a 24-hour urine sample, and of those submitted, 34% were inadequate by creatinine level. 28% of those requested to complete a 24-hour collection, therefore, had submitted a complete collection. And also, I think that as urologists generally, we don't necessarily feel comfortable interpreting the results. And this survey from the Endo Society of Endo Society members showed that 97% of endo urologists will perform metabolic assessment without onward referral. 37% would be more likely to metabolically assess if the results were easier to interpret. And 35% would actually like advice or assistance in interpretation of the results. So practically speaking, what are the investigations? Well, we've already looked at that low risk group who are shown in silver here. And these are just some blood tests, ICENIs. We will often do a bicarbonate as well, a calcium and a uric acid, and then a PTH if you think that primary hyperparathyroidism is a risk. We then got to look for this more detailed investigation. And this is certainly what is recommended by the AUA guideline. Metabolic testing should consist of 1 or 2 24-hour urine collections obtained on a random diet and analysed at minimum for total volume, pH, calcium oxalate, uric acid, citrate, sodium, potassium, and creatinine. That is expert opinion, but that's expert opinion from the AUA. And you can then match that up also with what we've already seen from the EAU guidelines. And then a stone analysis should also be done in all patients if we have a stone which can be sent off. And that is also recommended by the EAU guidelines, and that should be undertaken by infrared spectroscopy. We are getting better at being able to recognize stones as we don't always have a piece to send away, particularly with the new dusting techniques, but the stone isn't always exactly what we think it is when we've done an analysis just by sight. So we've looked at the EAU guidelines, we've looked at the AUA guidelines. So what about NICE and what happens in the UK? Well, you all know that NICE did publish the Renal and Uroteric Stone Assessment and Management Guideline in 2019. And regarding metabolic testing, they said we should consider a stone analysis for adults with uroteric or renal stones. We should measure serum calcium for adults with uroteric or renal stones. And we should consider referring children and young people with uroteric or renal stones for pediatric nephrologist for assessment and metabolic investigations. So it's much less specific and precise as to exactly what we should do from a metabolic testing point of view. But when you look at what it says about preventing recurrence, it says that we should discuss diet and fluid intake with the person, and they should be drinking 2.5 to 3 litres of water a day. We should be adding fresh lemon juice. We should advise patients to avoid carbonated drinks. We should advise patients to try and limit their salt intake, and also advise them not to restrict their daily calcium intake, but maintain a normal calcium intake of around 1,000 milligrams a day. We then look at what they actually recommend regarding pharmacological treatment. And they say that we should consider potassium citrate for adults with recurrence of stones that are predominantly calcium oxalate, and consider potassium citrate for children and young people with recurrence of stones. But it gets interesting when we look at the thiazide recommendation, because here in the thiazide recommendation, even though they've not recommended us to look at a 24-hour urinary calcium, they say that we should be considering thiazide for adults with recurrence of stones that are predominantly calcium oxalate and to have hypercalciuria. So clearly, they must think there's some benefit to doing this, and therefore I'm not quite sure how we can give thiazides to patients if we haven't done the investigation to find out that they actually have hypercalciuria. Then if we look at their recommendations for research, they are recommending that we need to have more extensive studies in the future to look at whether metabolic assessment compared to standard advice alone is clinically and cost effective. So there's clearly some questions in their minds around the benefits of full metabolic testing. So in summary, I think that we should be doing a detailed workup in high-risk patients. It's recommended in the AUA guidelines and in the EAU guidelines. Personally, I think the NICE guidance is a little bit confusing, as I hope I've demonstrated to you. And I think, therefore, it's clinically beneficial and also financially beneficial. Very, very sad occasion when Oxford chances in the boat race were sunk by fierce winds in a race not that recently, to be honest, as you can tell from the picture. But I'd say that the Oxford chances in the metabolic debate have been sunk by the evidence and by the guidelines from the EAU, from the AUA, from NICE, and from the RCTs that I've showed you. Thanks very much for your attention.
Ollie, thank you. That was really succinct, absolutely brilliant. Should we go straight into Ben, your view on life, and then we'll have a think about some questions to both of you at the end. So over to you.
Thank you. I will just get my slides up. Sorry, 1 second.
I think we're almost there. Yep, we got you.
All good. Thank you very much.
Yep,
Good morning, and thank you very much for the invitation to present the counterpoint to the metabolic argument. My name is Ben Turney, and as Stephen said, I've known him for many years, since I was his SHO in Oxford many years ago. And I continue to work in Oxford, and delighted to debate with my good friend and colleague, Mr. Wiseman. So as you know, I will be debating, how do I get this to advance, against this motion. So as Ollie says, this is the Battle of the Blues, and a week tomorrow we'll be facing the Cambridge rugby players at Twickenham. I look forward to being there to seeing Oxford trounce the Cambridge team, which I think is the likely outcome from that match. These are my disclosures, and as Ollie well knows, the company that we talked about earlier has dissolved 3 years ago, so I can clearly talk on this topic against metabolic stone without any conflict of interest in this area. So I'd encourage you to beware of Mr. Wiseman's convincing anecdotes. He's a very good orator. He's a very well-disciplined academic. He learns the literature and he presents it extremely well. He'll give you stories of disappearing stones and clever diagnoses that are beyond most urologists in terms of coming to these conclusions. But let's not put this to one side, and let's actually look at the facts as he tried to present to us. So this is the NICE guidance from 2019. Now, NICE has a very rigorous approach to providing guidance. They don't publish expert opinions, they don't publish sort of suggestions, they have very clear terminology, and they base this on a rigorous method for analysis. So they look at RCTs, randomized controlled trials, and really try and present evidence where there really is true evidence rather than clinical opinion. So what are we obligated to do under the NICE guidance from 2019 for stone patients? Well, these are the 3 things under metabolic testing. We should consider stone analysis. This means that if we can get a stone, we should try and send it, but it recognizes the fact that we can't always do that. We should measure serum calcium for patients with stones. And obviously for children who are high risk for metabolic diseases, these patients do need involvement because children with stones are likely to have recurrent stone episodes and an underlying potentially genetic disorder, which may be amenable to treatment. This is all very sensible and all very evidence-based. And this is why the committee have made these recommendations. The stone analysis is important because it allows us to pick up those rarer stones such as cysteine stones and uric acid stones, which then can be readily treated, and with medication we've got very good evidence base for how we treat these patients. Uric acid stones can be obviously dissolved with metabolic treatment to alkalinize the urine, and the serum calcium is a simple test, relatively cheap, that allows us to identify primary hyperparathyroidism, and again there's a surgical treatment for this which potentially will prevent them having hypercalciuria and further stone formation. So very sensible and robust advice. But as Ollie has pointed out, unlike the EAU and AUA guidance, it does not support 24-hour urine testing. So what I'm saying is that we can accept the NICE committee guidance on metabolic screening. There's good evidence for that, and I'm not going to fight against that. But really, what is the role of a 24-hour urine test in the stone former? So if we were to try and justify 24-hour urine collection, how would that be done? And we've heard some of these arguments from Ollie already. We're going to target high-risk patients because these are the ones that are most likely to benefit from intervention. We're going to try and identify rare conditions which might be treatable. And as we said, the uric acid stones and other stones like cysteine stones are those that could be identified for treatment. But if we're going to do it more routinely, we need evidence that actually alters the management beyond just giving the patient sensible generic advice. And we also need evidence that the drug management does reduce the risk of recurrence. And this is where, as Ollie pointed out, there is still ongoing confusion. So the committee knows that there are medications that can alter urinary biochemistry. So if there's a patient with high calcium levels in their urine, we know that thiazides will reduce that by causing a switch between potassium and between sodium and calcium in the urine. Similarly, if the patient has low citrate levels in the urine, we can give them potassium citrate, and this will improve their biochemistry. But these abnormalities can only be identified by 24-hour urine collection. Therefore, Ollie's argument is that we can't identify these things, we can't treat them without doing the 24-hour urine, and therefore it's necessary. But there is no evidence that performing these tests or altering the urinary parameters will reduce stone recurrence long term. And that's why the committee didn't feel able to add it as a recommendation routinely to do 24-hour testing. Yes, they've recommended research, but there is no evidence at this stage. The research needs to be done to determine whether it's a value, and some of that research has been done. So this is a paper that Ollie presented back from 2014. And here in the insurance-based system of America, where there's fee per service and clinicians are being paid to do extra tests, it's somewhat surprising if these tests are so good that there's only a 7.4% test rate. Now, Ollie might argue and say, well, this was in 2014, this paper, and that was before the AUA guidance, which recommended doing 24-hour urine collection. Surely over the last 8 years, the percentage will have increased. Actually, if we look more recently in 2020, the numbers of metabolic screens has actually gone down to 6.9% in this study, looking at nearly 500,000 subjects who had a 24-hour urine collection. 500,000 people who had stones, only 30,000 had 24-hour urine collection. And actually, year on year, there's been a decline in 24-hour urine utilization. So we're not doing more after the AUA guidance in the States, as I say, despite it being in an insurance-based system. And furthermore, doing that 24-hour urine did not show any benefit in terms of stone recurrence. So here, if you look on the axes, the y-axis is a 3-year recurrence rate of stone formation. And on the x-axis across the bottom here, you can see different categories of stone former. So the first couple of bars there are all stone formers, all comers. And you can see actually those that underwent a 24-hour urine test had a slightly higher recurrence rate in the 3 years after the 24-hour urine test was performed. Now you might say, well, these are obviously a high risk group. So they looked at other different categories. They looked at those who'd had stone surgery. There was no difference in those that had been screened with metabolic testing 24-hour urine between those that had the screen and those that didn't. They looked at specific high risk groups. Again, it didn't help. They looked at recurrent stone formers. Again, it didn't seem to reduce the risk of recurrence. And they looked at high risk and recurrent stone formers, and again, there was no benefit. So completing a 24-hour urine study in this analysis did not show any benefit in terms of risk recurrence. This paper earlier this year looked at 130,000 stone patients. Again, a similar percentage underwent a 24-hour urine collection, and over half had a stone recurrence within 5-year follow-up. What they found was that within the whole cohort, those that didn't have a 24-hour urine had a lower recurrence rate. So here you see this is a Kaplan-Meier over 5 years in the follow-up period. The red line here is those that didn't have a 24-hour urine collection, and they tended to have fewer stone recurrences, whereas those that had a 24-hour urine had more stone recurrences. Paradoxical, you might say. Well, perhaps the problem here is that the 24-hour urine collection is only being done on patients who are higher risk, and that's why it's being reflected in this way. So they sub-analysed this and did what's called propensity matching. So they look at patients of similar age, gender, and so forth, and match them. And again, they looked at the two cohorts. They looked at the time to a second stone and the time even to a third stone. And again, those that didn't have a 24-hour urine collection actually had a lower risk of recurrence. So surely there's something going on here. Perhaps it's something to do with the medication. So they then looked at those patients who'd had stone-related medication from the metabolic screen, thiazides, potassium citrate, etc. And this then categorized into 4 groups. those that had no 24-hour urine collection and no treatment, those that did have a 24-hour urine and no treatment, those that didn't have a 24-hour urine with treatment, and those with a 24-hour urine and treatment. And as you can see here, the red line, which is no treatment, no 24-hour urine, actually had the lowest risk of recurrence. And those that had a 24-hour urine with presumably tailored treatment had the highest risk of recurrence. So it doesn't seem that doing the 24-hour urine actually benefits these patients. And in fact, conversely, the treatment here doesn't seem to be really very helpful. Other studies like this one from last year in big populations, this one with 2-year follow-up, showed the recurrence. This is the recurrence-free probability. And again, there's no difference between those having empiric pharmacology therapy and those having targeted therapy. So if you're going to do a 24-hour urine, you'd think that that would then give you insight into the metabolic profile, and then the therapy could be targeted appropriately, and this would be a benefit. But this study doesn't show that. And they looked at all these different parameters in terms of visits to the emergency department, hospital admissions with stones, procedures they've had, and any adverse events, and none of them showed any difference whether you use empiric therapy or targeted therapy for stone recurrence. So it seems, as the NICE guidance says, as if there really isn't good evidence that doing a 24-hour urine and giving targeted therapy will influence recurrence. But beyond this lack of evidence, there are other challenges. And what are they? Well, as Ollie mentioned before, there are real challenges in sample collection. For any of us who've done 24-hour urine collections in clinic, patients really don't like it. And as Ollie's studies demonstrated, only a small percentage complete it and complete it correctly. There are lots of challenging logistics in giving out these bottles, collecting the right amount of urine, preserving it appropriately, transporting it back to the clinic. And this leads to poor compliance and therefore may influence some of these outcome data. As Ollie says, the second real problem is challenges in data interpretation. It's very challenging when you get a list of numbers like this with some units next to them, unless you're doing this all the time in clinic, to know where to start in terms of management. You may look at this and see that the 24-hour urine volume is relatively low and recommend increasing fluid intake, but there's not many people who could look at these numbers and instantly say, I'm going to start a thiazide, or I'm going to treat them for oxalate levels, or even is that uric acid level high, unless you're doing this regularly. So unless you're in the clinic doing this on a regular basis, it's difficult to know where to start with treatment. And if you don't know where to start, then there's probably no point in doing the test in the first place. And really the challenge is that if you're going to do a 24-hour urine analysis, it needs to be part of a full metabolic profiling. There's no point in doing the 24-hour urine analysis unless you don't look at the lifestyle. Is this patient in an occupation where they can't drink fluid? Taxi drivers or chefs? Does this patient have an unusual diet? Are they morbidly obese? Does this patient have metabolic risk factors that may specifically predispose them to stones? And so the 24-hour urine really is only one component of this, and doing that alone probably isn't sufficient to provide targeted therapy for patients. And as Ollie mentioned, compliance is desperately poor, so there's no point in doing this once, starting patients on treatment and leaving them off into primary care or into the community, because as we know, unless they're being followed up regularly and having motivation to do this, their compliance will be very poor. And as we mentioned in the title, there is obviously a cost to all of this. Now, there's an argument that doing this reduces stone recurrence rate, but as we can see from the data earlier, it doesn't seem that it makes a big difference to recurrence rate, and the cost of repeating these tests on a 6-monthly or annual basis and bringing the patient to clinic may not outweigh the benefits. But this is all very interesting from academics working in ivory towers, but are we just actually ignoring the elephant that's in the room? As Stephen said in his introduction, many areas with high stone preponderances have patients from low socioeconomic groups, and these patients are really not even prepared to comply with any simple changes in their lifestyle. So even the simple things that we can suggest to them, such as increasing their fluid intake, stopping drinking Coca-Cola and switching to water, and avoiding the sugar and carbonated drink load, they're not even prepared to make these changes. Many of these patients come into the clinic with very high BMIs, and we know that BMI is a risk factor for stone disease, and they're not prepared to make any weight loss adjustments, and similarly with diet adjustment. So actually, doing these fancy tests and maybe starting medication is perhaps completely negligible in terms of their stone risk when they have these much more predominant factors that are going to influence their health and stone well-being. And this is very well evidence-based. This is a large study from the UK Biobank, which we published 2 years ago, looking at around 500,000 patients. And here you can see the risk of stone recurrence, which is on the y-axis, drops from a sort of baseline of 1 to about half the risk. If you look at the x-axis here, you can see the fluid intake increases from just over 1 litre to just over 2 litres. So increasing your fluid intake from 1 litre to 2 litres pretty much halves your risk of stone disease. In fact, for every 200 millilitres additional fluid intake per day, that's approximately a 13% reduction in risk, which is probably much more powerful than medication and all the cost and expense and trouble of going to 24-hour urine collections. This study from 1996, which is quite famous from Borgi, looked prospectively in a randomized study at the value of fluid intake with 5-year follow-up. And as you can see, group 1 here, the dotted line, over the 5-year study, had a far less rate of recurrence, far fewer stone recurrences. This is 100 patients in each group. And you can see that by increasing their fluid intake on a regular basis, has a huge impact on stone recurrence. And this is clear prospective randomized data that fluid is really important in stone risk. And if we can't get this sort of thing right in our patient group, perhaps we're never going to succeed with more fancy tests and treatments. Similarly, for obesity, this study, which we published 8 years ago, looked at a European database of patients. There's about 200,000 patients in this group. And we looked at the relative risk of BMI. And as you can see here, going from a BMI of 20 to 22.5 up to a BMI over 27 doubles your risk of stone disease. This graph does plateau off. It's not linear as you go up. And so once the BMI is over about 30, 35, it sort of plateaus off. But having a high BMI is a significant risk factor for stones. So again, if patients aren't prepared to lose weight and change their diet, really, is there any value in doing more expensive tests if they're not going to be compliant with these basic lifestyle changes? And then there's dietary stuff, which is in the NICE guidance, is very well evidence-based. Again, this from the UK Biobank. There's just a few slides here to demonstrate this. We know that salt being added to your food increases your risk. These are forest plots. So as you go down from the top to the bottom, this is increasing salt intake. And anything to the right of the line is higher risk. So as you can see, the higher your salt intake, the greater your risk of stone recurrence or stone disease. Similarly, good things, healthy things are fruit, vegetables and fiber. You can see here that as you increase your fruit, vegetable and fiber intake, there's a steady decrease in your stone risk as the graph moves to the left. The white diamond-shaped box there is the sort of mean change across the group. Other dietary things that we know all about are meat intake. So the protein and the purines in meat push you to the higher risk. The more meat you and it doesn't really matter what type of meat it is, whether it's white meat or red meat, it seems to be the protein, animal protein per se is the main risk factor. So all of this, as we saw earlier in Ollie's talk, is all represented in the NICE guidance. Main thing is obviously to increase your fluid intake, decrease your salt intake, and to increase fruit and fiber. And I think we all know from the Gary Curran studies of the 1990s that calcium actually is protective up to a reasonable level. So patients shouldn't be advised to cut out dairy products or foods containing calcium, because actually calcium binds oxalate in the gut and reduces your risk of stone recurrence. So this is often a misconception that patients have from Dr. Google, is that they've cut out calcium, but they should be encouraged to keep a reasonable or even high level of calcium in their diet. So again, others have looked at this. David Goldfarb's a nephrologist in New York City, and he's proposed this idea of empiric therapy. But the cornerstones of this are the lifestyle, the weight loss, the fluid intake. And again, it doesn't really matter what the fluid is, it's just the volume really. And again, a diet, as we say, is low in sodium, low in protein, animal protein, relatively low in oxalate and reasonably high in calcium. And he's then also proposed potentially if patients are still getting stones and they're compliant with the above, which I suggest would not be very many people, you could add in empirically something like potassium citrate, which actually is going to be good for the majority of calcium oxalate stone formers. So to sort of come towards the end of my talk, I think we just need to think a little bit about how we manage stone disease. And I think this is a medical problem, and we have to think not like surgeons, but think like medics. Metabolic stone disease is a condition a bit like hypertension or diabetes, hypercholesterolemia. They're long-term, lifelong conditions. And what we have to balance is the risk benefit of taking daily medication versus the outcomes. And clearly for something like hypertension, there's very good evidence that if hypertension is left uncontrolled, patients suffer in terms of strokes, which are very debilitating. Similarly with diabetes, the microvascular and macrovascular complications of diabetes have profound effects on patients' morbidity and mortality, as does high cholesterol or hypothyroidism. So the benefit of taking medication on a daily basis for the long term is incredibly clear and very evidence-based in the literature. It's less clear to see that for the metabolic side of stone management. And part of the problem with that is the complexity. It's not one condition. So within metabolic stone disease, we can do a decision tree, something like this, where we're looking at calcium stones versus non-calcium stones. And for the calcium stones, the majority of these will be calcium oxalate, but obviously there's an important phosphate subgroup. And then if we look at a management of this, the management becomes potentially complicated. This particular picture does not include the calcium phosphate groups, but as you can see, if you go through this, this is a decision-making tree. But to do the decision between calcium and non-calcium stones, you need to do the stone analysis, otherwise you don't necessarily know what you're dealing with. But if we look at a graph like this and break it down, how can we sort of think about things? So if we're going to go into this, we need a personalized approach where we look at all of this, and it all has to be done very properly and thoroughly to personalize the treatment. And that's often very challenging, or if not impossible to do in the current climate. But if we look back at the graph I just showed you there, what we're thinking about is how do we manage the population of stone patients? And the nice recommendations, which I showed you earlier, will pick out some of these key groups here. So the ones that are circled here, the calcium, non-calcium stones will be identified by stone analysis. And this is obviously important because these are treatable and preventable. And similarly, doing a measured serum analysis of calcium will identify Hello. Sorry, doing a serum analysis will identify patients with hyperparathyroidism for treatment. But for the majority of stone formers with calcium oxalate stones, which remember makes up about 80 to 90% of stone formers, they'll have infrequent recurrences. They'll remain exceptionally well between episodes. They won't comply with basic fluid, diet, and lifestyle changes. They won't comply with investigation or follow-up or long-term treatment. And so therefore, the value of doing the metabolic screening really should be questioned. Thank you very much for your attention.
Tell you what I've done over the years. So I've moved hospitals a couple of times. When I worked in a very large hospital with, again, a population with a lot of comorbidity, I devoted a huge amount of time in my stone clinics to screening and preventative work, and found exactly that the urine volumes were low because they didn't complete the tests correctly. They either didn't complete them at all, or we got 200-300 mils of urine back, and you were dealing with really highly comorbid patients who were never going to change. And I saw one of these on Wednesday. He was a young man with a 1 centimeter renal stone that had bobbed in and out of his renal pelvis. He was 136 kilos. He smoked. He was diabetic. His diastolic blood pressure when I saw him 4 or 5 months ago was 115. I brought him back, gave him intensive lifestyle advice, and brought him back to see if he had changed. He was heavier. He was continuing to smoke, and his diastolic blood pressure was 120. And he's 39 with a 1 centimeter renal pelvic stone. I said, essentially, at the moment, you are untreatable. I cannot give you lithotripsy, and I don't think anybody's going to put you to sleep. And those are our real patients. And I wondered if you both felt, is there a difference between the NHS and the private sector? When I did do private practice, that was when they were motivated and you could talk to people reasonably about reducing their blueberry intake, for instance. But doing that out in the peripheral clinic is really difficult. Any thoughts?
Ed, I think you've got
I might be muted.
muted.
Yeah. Shall I go first, if that's all right?
Yeah, thanks. Yeah.
Thanks, Ben. You made a really compelling argument, and you know, I think with these things, there's not necessarily a right answer, and I think a lot of it's about seeing, as you've indicated, Stephen, you know, exactly how interested the patient is, because some patients won't be interested at all, and others will. But I don't think we're doing our patients a service if we kind of look at the you know, literature and say, well, generally patients aren't that interested, generally patients don't comply. And so I think we have to offer every patient as much advice as we can in how to reduce their stone risk. And it's up to them then, a little bit like you were, you know, doing with your patient, Stephen, whether they take it or not. We can't say that because a patient's not going to take our advice, or, you know, out of 100 patients, you know, 95 aren't going to take our advice, that therefore we don't do the investigations to see what advice we think is most appropriate. So I think we do our patients a little bit of a disservice if that's how we treat them. The frustrating thing is, from the point of view of the patient you're talking about, Stephen, that you saw in the clinic, is that, you know, these are the patients who are going to benefit the most from, you know, medication, lifestyle advice, and that sort of thing. Not just from the stone point of view, but also, as Ben pointed out, from all those other comorbidities that are going to, you know, cause them a lot more trouble than their stone will. So I think that, you know, possibly some private patients, or the proportion of private patients who are motivated, is a bit higher. But certainly, you know, we don't differentiate between the patients that we see in the NHS and the patients we see in private practice. We've got a busy metabolic stone clinic in Addenbrooke's that we run with one of the renal physicians, and we will see all the kinds of patients who, you know, who we, or, you know, who I talked about in my presentation, and I would say that a significant proportion of them are motivated. So I do think it's something that we should be offering to people.
Did you think the socio-economic class plays a big role? Because obviously your populations in Oxford and Cambridge are different. They are possibly better educated, they're younger, they're probably more diverse than other parts of the UK, better well-read, for instance, and I suspect better motivated than many of the poorer parts of the world, that certainly aren't the poorer parts of the UK that I certainly worked in. Zaf, is it worth saying what we did? Because we changed our policy here when I arrived about a year ago, based on looking at NICE and EAU guidelines and the real practicalities of it.
Yeah, yeah. So we did, obviously, we took all of this information to heart, and then we stopped routinely doing 24-hour urine collections as per the guidance, really. But we are very lucky to have an in-house metabolic consultant. And one of the things that occurred to me, Stephen, is that I don't know whether Ben and Ollie, you have a view on this, but maybe it's time to hand this over for the recurrent stone formers to a clinical biochemist. And now I know not all trusts have clinical biochemists, but maybe instead of surgeons trying to be physician-like, we should hand them over to the physicians who have that expertise. Do you have a view on that?
Should I go first on that one?
Yeah, do.
So we've had a clinical biochemist in our metabolic stone clinic in Oxford for some time. I think as part of a MDT type process, it's very useful and very important. But I think it's really important also to have the clinical input from urology as well, because at the end of the day, you're trying to prevent this patient from having another stone and having further surgery. And the biochemistry is only one part of it. As I sort of mentioned in my talk, we're not just treating biochemistry, we're not just treating the urinary parameters, we're actually treating the patient long term and thinking about things more holistically. So I think they add a value, but I think to hand it over to them and not remain involved actually does the patient a disservice. And probably what we need to do rather than that is educate more urologists to be part of that team and to have a better understanding, because they're the ones that are going to see these patients and screen these patients for metabolic screening. So their involvement is critical, and their understanding of metabolic processes is really important.
But other than you two, I don't know many people in the UK have a great interest in metabolic stone disease. We tinker with it, but I think everyone's too tied up with their surgical side to get really involved in it. Do you think there's a gap for more urological clinicians spending a day a week doing metabolic stone disease?
Yeah, I think there are some other pockets around the country. So Southampton has quite a strong metabolic stone clinic. Newcastle has a quite a big metabolic clinic, I believe. And I think there are other centres around the country that do this. In London as well, UCL do quite a lot of metabolics, and the Royal Free. So I don't think we're unique in that regard. Perhaps it relies on a bigger centre where you've got that ability to get nephrology and clinical biochemistry and everybody else involved. And it is a challenge perhaps in a smaller centre where you don't have the same resources. I appreciate that. But I think it is something that, we have a responsibility to these patients. And it's a bit like when a patient presents with lower urinary tract symptoms. Actually, often it's a manifestation of many other health issues that the patient's got. And we probably should take every opportunity to try and improve the overall holistic care of our patients. And even if they don't, as Ollie says, abide by weight loss and fluid management, it shouldn't stop us from telling them. It's like, just saying, oh, people aren't going to quit smoking. There's no point in telling them to quit smoking. We should continue to do that and continue to tell them the benefits.
Thanks very much, Ben. Sorry, Ollie, were you about to say something?
Yeah, just to make a point. I mean, you mentioned clinical biochemist. I think the one group that we really need to get involved in these patients' care also are dietitians. Because they have a fundamental role in advising patients, not just about the reduction in stone disease, but also in weight loss and how to do it. And often, these patients will be diabetic as well, and they'll be balancing all these different balls, and they'll be like, I can't take any more dietary advice on board. What am I going to be able to eat? I'm trying to lose weight, so I've been cutting out all of the things that contain oxalate. All of the carbohydrates. I've been trying to have more fruit and veg in my diet, and now you're telling me I've got to stop eating a lot of the vegetables that I should be eating to try and reduce oxalate. So I think having a dietitian also involved would be important. But I agree with Ben. I think that we have a fundamental role to play, and if we're not involved in those clinics, then we tend not to think about referring patients. We're very surgically minded, and we like to operate. But from a patient's point of view, we have patients absolutely begging us to do what we can to try and reduce their risk of recurrence. And so I think having that holistic approach with renal physicians, with clinical biochemists, with dietitians, for those who are motivated, is really important. And I'd encourage people, if they haven't got those clinics set up, to try and do that.
Exactly.
Thanks. Yeah, I've really enjoyed listening to both of you today, Ben and Ollie. And if I could ask you just to put the oars down for a moment, and just take you back to one of the guidelines. I think you were looking at. I think it was the NICE guidelines, Ollie. You were talking about, and I really like the idea, by the way, of empiric therapy, and you were talking about Goldfarb's paper, Ben, as well. But in terms of calcium oxalate stone formers, recurrent stone formers, starting them on bendrofluozide yourself, what advice would you give to other urologists, and how comfortable do you feel doing that yourselves?
Yeah, so I think the thiazide thing is interesting, and the question here really is about compliance as well, because if you're starting these medications, you have a responsibility, like any physician, to monitor these patients. What you can't do is just start these treatments and then sort of dismiss them into the community, because there are potential side effects from thiazides, there are potential side effects from potassium citrate. So I think if you're going to go down the route of prescribing, you have to take ownership, and you have to take ownership of the follow-up as well. So that, I think, is a really important issue. But I think, we do prescribe lots of medications in urology. We're one of those great specialties where we don't really have a sister medical companion specialty, and that's one of the attractions for many urologists, is that we do give, you know, tamsulosin and finasteride and medications for overactive bladder and all sorts of things. So we're not just surgeons who operate. We can prescribe, and it's just about having the confidence and the education to do it. And I think we could do that if we wanted to. There's no barrier for us.
Yeah,
Guys, thank you. Sorry, Ollie, go ahead.
No. I'd say, you know, I completely agree. And, you know, from a thiazide point of view, particularly for the patient who's got hypercalciuria, I think it is beneficial. You know, we talk about Bendro all the time, but the thing to do before you start patients on bendroflumethiazide is just to check their blood pressure. And if their diastolic blood pressure is on the low side, they're not going to tolerate it very well. So in those patients, I would usually start them on indapamide at a dose of 1.5 milligrams a day. So it's really, you know, something that we should be thinking of doing for our patients. And as Ben says, we prescribe medication all of the time.
And conversely, if they have got hypertension, then potentially you can kill two birds with one stone.
Yeah, exactly.
Brilliant. Guys, thank you so much for giving up your morning for us. Really, really good. I think I know what I should be doing. Whether we have time to do it is another thing, and whether it will change anything in our satellite clinics, I really don't know. I've really enjoyed it, learned something. Thank you again.
Thanks very much. Take
Thanks,
care.
Stephen.
Thank you.
Take care.
Thank you.
Thank you.
Yeah, see you, Stephen. See you there.
Thank you. Ed, can you bring up my talk if you could? So we're going to move from biochemistry now to an everyday clinical problem of trying to avoid a negative ureteroscopy. In modern urology practice, is it safe? Is it acceptable to operate on a patient and find no stone? Can I have the control if I could? So I'm going to ask you a question at the beginning here, theoretical question. Firstly, my disclosures. I have no personal disclosures. The meeting today has been sponsored by, very kindly, by Boston Scientific and Wolf, who've paid for our camera team and our IT. So this is a theoretical case. January of this year, a 58-year-old male turns up to the emergency department with a proven left 5mm mid-ureteric stone. This is the public NHS sector. And it doesn't really matter whether he's stented or not. We'll say he is stented. And he's given a date for definitive surgery. And we can debate about primary ureteroscopy and the practicality of that. And his date is not that far away. It's about 5 weeks away. You meet him for the first time on the day of surgery in the day surgery or ambulatory department. Are you going to re-image this man or are you going to operate on him? And how are you going to consent him for this procedure? This interested me because I was involved in a case exactly like this, who had a very short timeline. The timeline from renal colic to getting on a theatre list was 10 days or so. And when I saw them in the day surgical unit, met them for the first time, they described being in agony. The CT was only 2 weeks old, and they had a catastrophic anaesthetic-related complication before I went anywhere near the patient. And this went to a legal case, and the lawyers said things along the line of, why didn't you do a CT urogram on the day to prove the stone was still there? So let's look at some evidence. We all know the complications of ureteroscopy. We consent for these day in, day out. Failure of access, roughly about 10%. The need for a second procedure, and I put these points in red to really stress them. Ureteric trauma, but not just the fact that it's roughly under 1%, but what are the sequelae of ureteric trauma? You could have a devastating ureteric injury. You could have a small ureteric stricture. You could end up with reconstructive surgery. You could end up becoming stent dependent for the rest of your days. And there are legal cases that have brought all these to light. One of my interests is in medical legal urology. So sepsis, patients are terrified of sepsis, but what does sepsis mean for them? It might just mean a couple of days of antibiotics in the ward, but it might mean a visit to intensive care and some catastrophic complication in intensive care. Now, I have colleagues who will go further down the line and talk about septic showers, loss of organs, loss of digits. I don't go that far, but trying to expand what sepsis means for the patient. Myocardial infarction, DVT, pulmonary embolus, and death, I put on every consent form. Not everyone does. Anesthetic-related complications. And again, these are out of our control. And I'll give you an example of this. I was in the theatre recently, and I thought my anesthetic's taking a little bit longer than normal in a highly comorbid, very obese patient. I went into theatre to find a failed airway. The resus team there struggling to get a tracheostomy in, which they couldn't get in, blood everywhere, and SATs around 80%. Again, I hadn't touched the patient yet. So do you talk to your high-risk patients about this? Stent pain, we've seen this day in, day out in our practice, and the patient who is on the phone to your PA or your secretary every day saying they cannot tolerate their stent. Do you stress how severe it can be? So how common are these complications post-ureteroscopy? There are many, many studies you can choose from. I've chosen one here of from the CROES data of just under 20,000 procedures, which gave an overall complication rate of about 70% by Bhaskar-Somani. Avulsion. I've avulsed a ureter. I avulsed a ureter right at the beginning of my career. I never want to do it again nor see it again. It happens in less than 1% of cases. Postoperative fever is common, we know that, roughly 1.8%. Some form of urothelial injury. Olivier Traxier shows lovely slides of grading ureteric trauma from access sheaths post-ureteroscopy. But what are the sequelae of having a urothelial injury? It doesn't heal. You may end up with a stricture. If you don't re-image them, you may end up with loss of that renal unit later on. Is all this part of your informed consent? Bit of hematuria we know is commonplace. Ureteric stricture I've mentioned. Sepsis is rare, but can be catastrophic. And something I don't think we think about, that when you've been up and down the ureteric orifice many times with many different devices, you can occasionally lead to persistent reflux. So, is negative ureteroscopy really a problem? I think it is. I think it is. So this was a paper published in 2017, and I think it was a British paper. 1,256 patients who underwent ureteroscopy for stone disease revealed a median preoperative stent time of 62 days. And something we've looked at here, and we'll probably debate at the end about stent dwell time versus primary ureteroscopy. So these patients had their stents in for a couple of months, and it showed that the interval between emergency stent placement and the definitive surgery raises the likelihood of spontaneous passage and subsequent negative ureteroscopy. And one of the summaries of this paper was that negative ureteroscopy exposes the patient to risk and represents poor utilization of hospital resources. This is some work I published in February of this year in the Annals of the Royal College of Surgeons, where we looked at 257 stented patients with an average stone size of 7 millimeters, average stone density. Most of them were in the upper, some in the middle, and about a quarter of them in the lower third of the ureter. So we split the group into two, those that had received preoperative imaging and those that didn't. And it showed that if you image the patient preoperatively, the question is when, you can significantly reduce your incidence of negative ureteroscopy from 14% to 6%. So same study. What are the predictive factors? Well, they're fairly self-evident. Stone size was statistically the only significant predictor of a negative ureteroscopy. Remember, this is in the stented group. Surprisingly, not surprisingly, sorry, the greater the size of the stone, the less likely the ureteroscopy would be negative. With each millimeter increasing stone size, there was a roughly a quarter reduction in the likelihood of a negative ureteroscopy. Again, that could come into your preoperative consent. It could come into your preoperative discussion at a stone MDT or committee prior to surgery. And we found that age, gender, stone location, stone laterality, stone density, stent duration in this study, positive urine culture, raised inflammatory markers, or renal impairment were not predictive of whether you would get a negative ureteroscopy on the day. So let's change to the some international data. Let's look at the stented ureter again. 194 patients with indwelling stents, a significant negative ureteroscopy rate, 14%. This figure comes up a lot. There are some papers which go up to 25%. And again, show that small stone size and distal location this time were statistically significantly associated with spontaneous stone passage. Another paper from 4 or 5 years ago, 200 patients reported stone passage rates of 8% with stents, with indwelling stents, assessed either at subsequent ureteroscopy, which was negative, or on follow-up non-contrast CT. So that we're getting a pattern here of the prevalence of a negative ureteroscopy. What about the unstented ureter? So the Endo, big paper, 20,000 patients, found a negative ureteroscopy rate of 6%. And in this paper, much bigger patient numbers, female gender was associated with negative ureteroscopy. 2011, 250 renal units with both renal and ureteric stones. Again, similar rate, 9%, found that smaller stones and a distal location were associated with negative ureteroscopy. What about the effective waiting time? So the NICE guidelines said that we need to get on and treat these patients as acute surgical emergencies and offer them definitive treatment within 48 hours. Now, in most hospitals, you can't offer definitive treatment within 48 hours. Most hospitals do not have a fixed site lithotripsy in the UK. And as we heard at the Royal Society of Medicine last week, even big London teaching hospitals struggle to get their patients on the emergency operating list. The bigger your hospital, the more likely you are to have other specialties such as vascular and transplant queuing for the list, the less likely are you to get on for a primary ureteroscopy on a Saturday night. So a Spanish paper, in a Canadian journal, so European data showed that long surgical waiting times are associated with an increased rate of negative ureteroscopy. And it's something we've looked here at our stent dwell time before the COVID era and during the COVID era. We talk about that later, about how that changed. So they looked at 200 patients and just under half of them were stented, slightly higher negative ureteroscopy rate at 18%. But the time with stents in place, median was 74 days. Variables protective against a negative ureteroscopy were, as before, large stones. Bizarrely, the presence of a temporary double J stent, temporary they mean it, not without strings, but it's sitting there for a period of time, and radiopaque stones. A long waiting list time of greater than 60 days increased the risk of negative ureteroscopy, but unusually was not associated with an increased risk of complications. That may be statistically correct, but if you have an unhappy patient who's waited, stented, and is in pain for that period, they will not be reassured by those data. So the end of this study showed that a long waiting list time with a stent in place has an independent, direct and linear correlation with finding a negative ureteroscopy. Right, what about radiation exposure? So plain films are really going out of fashion. That the dose from a plain abdominal X-ray is pretty much identical these days to a low dose CT scan. So a low dose CT scan and an ultra low dose, should I say, of less than 1 millisievert are increasingly used to reduce the level of radiation exposure. One of the problems I've found over the past 10, 15 years is that by reducing the dose, you reduce the quality of your scout film. So with an old-fashioned CT scan, you could often see the calcium-containing stone on the scout film, which meant you knew whether to use a plain film on the day of admission for ureteroscopy. The ultra-low dose CT, which we use here, a scout film is often not of great quality. So the protocols are limited by image quality. and the sensitivity and specificity does change between low dose and ultra low dose CT, but they're still pretty good, better than plain X-rays. There is a further deterioration in detection rate in the obese patient, which is a BMI over 30, and in patients with small stones. I think we should put into that equation as well, what are you looking at these images on? Are you looking at them on your laptop? Are you looking at them on a hospital computer? Or are you looking at them on a high resolution screen? Plenty of times I've looked at a CT scan on the day of surgery, said I can't see anything, gone to see a radiologist on their large screens, and they point out the stone to me with a bit of computer manipulation. So, as my last slide, has your opinion changed? Let's go back to this patient and I'll talk you through his story again. He's 58. He presented with a 5mm mid-ureteric stone. It's in the public sector in the UK. He's dated for a definitive procedure, and you meet him on the for the first time in the ambulatory department for a ureteroscopy. Are you going to image him? How would you consent the patient? My experience of this going wrong and a patient having a complication was before the NICE guidelines, where we are now meant to be offering definitive treatment. But we acknowledge it is very difficult to offer definitive treatment. A word of caution, even if you cannot offer lithotripsy in your hospital on a Saturday afternoon, you cannot offer primary ureteroscopy in your hospital on a Saturday afternoon. I think you have to have that discussion with the patient, saying it is theoretically possible. I could try to send you somewhere else, but on a bank holiday weekend, it's not going to happen, or we can temporarily stent you. So the case I was involved in sued the trust. The expert witnesses on the trust side said, actually, it's not standard practice to do a CT urogram on the day of admission, or even at that time, which was some years ago, to do a CT scan on the day of admission. So they turned their attention to the radiologist, who was a good uroradiologist, and brought up 3 expert witnesses to say it's a phlebolith, not a stone. A figure that it's worth you remembering is that even a CT urogram will fail to opacify the lower ureter in between 20 and 30% of cases, and again will be non-diagnostic, and in some series over 30% of cases. So has it changed my practice? I operate towards the end of the week. I review my cases either the week before or on the Monday of that week. If their CT scan has been some time ago, I will re-image them that week. I don't know the answer to when is an up-to-date CT scan. Theoretically, it's out of date the minute it's done. I still get it wrong. I still look at a CT and think it's there or it's not there, and I'm surprised to find a stone or surprised to find the stone is gone. But I think by imaging on the day, whether it be with a plain film or a CT KUB, or a couple of days prior to surgery, you can try and reduce the risk of your patient having an unnecessary procedure and exposing them to unnecessary risk. And if I was giving evidence or as an expert witness for a patient, and virtually all my work is for patients against hospitals, if the CT scan had been performed a couple of months before, and that patient had a complication related to their surgery, I would be critical of the management of that patient. So I'm going to leave it there. Zaf, I want you to talk to us about our dwell time, because that's something we looked at when COVID was happening.
Yeah, absolutely. Well, that's a really interesting talk, and I think in Colchester, I've developed the pathway a long time ago, but in some ways it hasn't changed. We've always identified stented patients as a very vulnerable group, and we've always worked very hard to try and reduce the time between time of stenting and time of ureteroscopy, and we've done that through a suite of measures, actually. First of all, encouraging primary ureteroscopy wherever possible, and you've already outlined the difficulties there are with delivering that in real life, and obviously the guidelines, well-meaning as they are, will make that more of a priority with us. But also giving patients some empowerment. We give them all stent cards, which gives them the expiry date and all that kind of stuff, and putting them onto what we call a stone target list, which means that stone targets are treated almost a bit like a cancer target patient. They have their own separate pathway, which gives them clinical priority. And that's obviously very important. And in that way, we've managed to keep the indwelling stent time down. But interestingly, the indwelling stent time, and you caught me on the cuff, I can't tell you exactly what it is, but it's something like 6 weeks on average for this group of patients, did not change during COVID. So we audited that, and that was because we were able to use our neighbouring private hospital to carry on operating on NHS patients. And we worked very hard with the managers, and they understood that this was a vulnerable group of patients.
I think it's worth, how can we move towards this culture of primary ureteroscopy or primary shockwave lithotripsy? We use a mobile machine. We're about to have our fixed site machine placed here, but most hospitals in England don't have fixed site machines and really struggle to access emergency lithotripsy. When I go and see a ureteric colic patient with the duty registrar who may have already listed them for an emergency stent, the first thing I say to the team is, let's just stop and say, does this patient really need an operation? You've told me he's in pain. Let's really scrutinise the drug charts and say how much pain relief this guy really, or this lady really had. Is it enough to justify them sitting on waiting for an emergency operating slot? And again, I'll give an example of a legal case I've given an expert witness opinion for, where I scrutinised the drug chart and said, actually, come on, guys, he's only had 10 milligrams of morphine. That's not uncontrolled pain. You could have sent him home and offered him a definitive date for a primary ureteroscopy that week or the week after. Many hospitals now have the ability to offer a hot surgical list, and we're lucky enough here to do that once a week, where if we admit somebody on a Monday who needs his stone removed, we'll try and save them up till Thursday or Friday and admit them as an elective patient. So I think we should be doing everything we possibly can to avoid stenting. It wastes money for the NHS, and it causes pain and distress and exposes the patient to a second risk.
I think you're absolutely right. You know, avoid the stent in the first place wherever possible. You know, if you do have to put a stent in and bring a patient back for the ureteroscopy, try and do it as soon as possible. Now, coming back to the idea of doing a CT, that's going to be a paradigm shift, but it's one that we ought to embrace. I think we now have ultra low dose CT. We should be moving towards getting that CT before the ureteroscopy, and I think that's something we're going to move to this year. One thing occurred to me. Tommy, who's giving a talk this afternoon, came on a different day to, I think it was a regional meeting, and he gave some evidence which really worried me. It basically showed that if he basically looked at all the CT scans and worked out that even if you do a CT, you could quite often miss the stones, or rather the CT misses the stones. The stone is there, but you can't see it, which is obviously a huge concern.
So those sensitivity levels I showed earlier in specificity for traditional CT and low dose CT do show a slight drop in sensitivity and specificity. And I think that the viewing screen makes a real difference. So if you're going to make a call on the day and you are unsure, I would recommend you run that past a radiologist rather than make the call yourself on a PC or a laptop. I think we'll probably leave it there now, because I think our keynote speaker is logged in from Chicago. We'll try and bring Amy up now. So I'm absolutely delighted and really excited to welcome Amy. And I know it's really early o'clock in Chicago. When I was a registrar, there were these big names in Endo Urology that we all knew about. I was lucky enough to hear Joe Segura speak, and Ralph Clayman and Arthur Smith were at their peak. And then the next generation of superstars comes along, and there's no question Amy is one of those, but not just in one modality within Endo Urology and stone disease, a leader in her field in HOLEP. And although I don't do HOLEP, I listened to your webinar about 3 months ago on HOLEP in the chronic retainers and then the not needing urodynamics because the outcomes were so good. And that's changed my view on offering bladder outflow surgery to chronic retainers without urodynamics now. So we're really, really grateful. Thank you so much for putting some time aside to chat to us, and we'll give the screen to you.
Well, thank you so very much. That was a wonderful introduction. I really appreciate all your kind words. I'm just going to see if I can get my presentation mode here. So today, although I often speak about HOLUP, today I'm going to be talking about PCNL access and benefits, start to stop. And, although I do a lot of HOLUP, I do a lot of PCNL as well. And it's probably my favorite procedure to do. I do have multiple disclosures. I am a paid consultant for Boston Scientific, Luminous, Virtuoso, and Storz, and I'm a DSMB chair for 2 other companies. These are the objectives for the talk. Basically, we're going to review the different access techniques, ways to troubleshoot problems, and then briefly discuss exit strategies. I really like this study from Dr. Denstead. It's an older study from 2007, but it probably has the best PCNL outcomes that you're ever going to see published. And he showed that as you increase the surface area of the stone that you're treating, your stone-free rate decreases as you would expect. However, even with full Staghorn calculi, you can expect a greater than 88% stone-free rate if you are doing the procedure correctly. Another study by Opondo in 2012 showed that your outcomes improve based on the number of cases you do. So the sweet spot is somewhere between 77 and 120 cases per year. Characterized high volume stone centers as those greater than 77 cases a year, and low volume stone centers as those less than 77 cases per year. And they found that when you got above 77 cases, your probability of rendering the patient stone-free went up, and the probability of rendering the patient stone-free by stone volume also went up. However, once you got above 120 cases, your outcomes went down. So probably when you get above 120 cases, you're getting into the more complex stones, and it's more difficult to render those patients stone-free. Regardless of if you're high volume or low volume, your goal really should be low complications. Going back to the Denstead study, they had exceptionally low complication rates in this study. They had a urosepsis rate of 1.3%, a hydropneumothorax rate of 1%, and very few of their patients were bleeding at 0.8%. I actually remember giving a course with Denstead, and he now operates at hospitals that don't have blood available. He's like, my patients don't bleed, and I rarely, if ever, need to give a blood transfusion, which I think is a testament to skill and technique. However, we don't all experience those outcomes. And if you look at the CROWS database, which is a collection of over 5,500 patients, about 5,803 patients to be exact, across multiple countries and multiple surgeons, you see that the transfusion rate is a little bit higher, around 5.7%. And it's really associated with the ASA score, or the anesthesia assessment score of the patient, the stone burden, the operative duration. It didn't really appear to matter if the patient had a solitary kidney, but maybe a little bit higher in anomalous kidneys. So bleeding is something we need to be concerned about, and something that we need to be aware about. And I think bleeding is really truly associated with the access. We're putting a needle into the kidney. The access is what determines what vessels are going to be damaged, and that can determine how the case goes. I'm probably in the minority, but I still like fluoroscopy for PCNL access. I think it's reliable. I think it delineates the anatomy very well, and that's what I prefer to do. The way I do fluoro percutaneous access is I have a separate imaging table with the C-arm preferred over a Euro table, because I can rotate the C-arm around the patient. I like a smaller imaging intensifier, or a smaller II, about 9 inches, to try and keep the hands out of the field. And I use an under-table X-ray source, so this reduces operator exposure. When you have an under-table X-ray source, the X-ray will come up to the table, hit the patient, and then scatter to my feet, or will leak to my knees. If I have an over table x-ray source, the scatter will be back up to my face and chest, which I do not want. And then I try to do the procedure as efficiently as possible. So the anesthesiologist will put the patient to sleep on the transfer cart, what they brought the patient into the room in. And then I will do a flexible cystoscopy on that transfer cart on the table, place a sensor wire up the ureter and a ureteral catheter over that wire by feel. And then I put a bladder catheter in and then reposition the patient prone. This whole process takes about 5 to 15 minutes, depending on the obesity level and illness level of the patient, but is generally very quick, reliable, and easy to do. I do supine PCNL. I actually prefer prone PCNL because I have more area in the back to choose from multiple calyces. So I'll do the vast majority of my cases are prone, but I will do a supine when needed. You can do a PCNL in any position: supine, prone, split leg, lateral decubitus. They've all been described, but this is how I like to position my patient, with both arms up, a chest roll, and the knees and ankles padded. What's the difference between supine and prone? I think it's really more preference. So one meta-analysis looked at 1,469 supine patients versus almost 5,000 prone patients. And they found no difference in stone-free rates. They were in the 80% in both groups. No difference in bleeding, no difference in colonic injury rate, which was less than 1%, or pleural injury rate. The op times were shorter in the supine group, but they also had smaller stones. And the one difference they did find is it's difficult to control the irrigation. And I would have to agree with that. In the prone position, the kidney tends to fill up, so you have more visualization. You can easily flex the scope around to see, and you feel like you get a good view of the kidney. I feel like in the supine position, the irrigation tends to come out the sheath, which is a benefit in that it will wash fragments out. But as a negative, it's hard to flex the scope around and get a good visual, and the floor just gets soaked. No matter how hard you try it, it is a bit of a mess, I feel, in the supine position. But regardless of how you position patients, most patients, you have to somehow work around their limitations. As a tertiary referral center, I get the more complex patients with spina bifida, spinal cord injury, joint issues. And so instead of trying to force a patient such as this onto the table in a perfect position, I actually build the table up around this person. Multiple pillows, multiple towels, tape, anything to make sure that they are not forced to move their joints, and I can still get exposure to the flank. This particular patient had bilateral frozen shoulders, and so we created slings for their arms so that they could sit in this position. He couldn't extend his arms in the supine position, he couldn't extend them in the prone position, so we created this particular sling situation. Once you have the patient positioned, now you really need to think about where you're going. The vascular anatomy to the kidney is complex, but we do know that the segmental renal artery may cross an infundibulum. A medial puncture may increase the risk of injuring one of these segmental arteries. And I think this is something that we take for granted, but if you do injure one of these arteries, it can be life-threatening. And I know this from experience. I've done several thousand PCNLs, and I've had a patient where we injured a segmental renal artery, and we're lucky he was young and healthy because he lost a lot of blood. So it's nothing to be taken lightly. You really need to consider where these arteries are and take them into account. I prefer a puncture that is dead through the middle of a papilla. The precise mid-calyx puncture is the best possible outcome. It avoids the periinfundibular venous plexus. I try to go medial to the posterior axillary line to avoid the colon. And this is just a picture of when I pulled back the sheath on one particular PCNL, and you can see that this is dead through the center of the papilla. This is exactly what you want when you're doing these cases. However, maybe I'm wrong. I mean, nowadays we question everything, all the dogma, to see, what is correct. And historically, the papillary puncture has been what has been accepted as true and correct based on anatomic cadaver evaluation of the vasculature. We say that there's a 7 to 8% risk of a vascular injury when you use the precise papillary puncture. However, over the last 5 years, there's been a handful of publications examining the outcomes of non-papillary punctures, so challenging this dogma of this is how you have to do it. And most of these have come out of Greece. So in 2016, Karizis looked at 137 consecutive PCNL patients who underwent a non-papillary puncture. These were not mini PCNL, they had 30 French sheaths, and they included 10 anatomic abnormality kidneys. Their OR time was short, around 48 minutes, and 15.4% required a secondary procedure, either a secondary PCNL or ureteroscopy. And their stone-free rate after the secondary procedure is around 99%. What's interesting is their complication rate was fairly low at 10.2%, which was similar to what you saw in the Crows series, which was around 4 to 7%. Their transfusion rate was only 2.9%, so lower than the Crows series. And they had no grade 4 or 5 complications with a low mean blood loss. So they challenged the dogma and they had no worse outcomes. They went on to do a prospective randomized trial that was published in the Journal of Endo Urology in 2017. And they had stone burden that was over 2 centimeters. They had 27 papillary punctures, 28 non-papillary punctures, and they found no difference in transfusion rates between the group. They felt like the OR time was higher in the papillary puncture group, probably because they're trying to be more precise with where they put the needle, but they had equal complication rates with no difference in hemoglobin change or creatinine. So in their limited small series, they found no difference. And this is just some images taken from the publication. You can see they have a large lower pole renal pelvis stone. And instead of where I would go, which would have been this lower pole calyx to clean this stone out and go up, they just went straight into the pelvis, cleared the stone, and then looked around with the scope and put a big reentry Mallinckrodt in. Subsequent studies have found very similar results with mini PCNL. A total of 32 patients, one-step tract dilation at 22 French, and again, they found a complication rate of around 9% with no increased risk of bleeding. So overall, small studies have shown comparable complication and bleeding rates with reasonable stone-free rates. Based on these studies, there is, limited data, but it sounds safe. I have to say, anecdotally, the one patient where I hit a segmental artery is when I attempted to use this technique. So there clearly is some issue with how you do it, and there's some something specific at how they're doing these procedures as opposed to the general urologist. So I still teach my residents and fellows that we should be going forward with papillary puncture and trying to avoid any periinfundibular veins or arteries. So if I'm going to puncture the lower pole, the first thing I'm going to do is identify the ribs. I'm going to find the tip of the 12th rib, go 1 finger's breadth below and 1 finger's breadth medial to the tip of the rib. If I'm doing an upper pole access, that will be a little bit different. I'm going to vary my skin puncture site based on how the kidney lies. I may have to go between 11 and 12. I may be able to get underneath the 12th rib, but it all depends on how the kidney sits when the patient is prone. But to be sure, I never go anterior to the posterior axillary line. This was a patient that was sent to me who has a nephrostomy tube through his colon, and you can see that his posterior axillary line is right here, and you have a nephrostomy tube way anterior. This is too far anterior, and you're going to hit the colon. I'm always shooting for this Brodell's line. Whether or not it actually exists, I don't know, but this is what we were taught in medical school and residency, and this is what we believe, that there's a posterior lateral line through the kidney that's relatively avascular. And my goal is to go through this area and into the papilla. Fluoroscopically, I feel like it offers the ideal delineation of the calyceal anatomy. I generally use an 18 gauge diamond tip needle. And there's two different techniques that are available, and I will switch between the two, eye of the needle and triangulation. With eye of the needle technique, what you're doing is you're actually positioning the C-arm in the same plane as the kidney and the calyx. And what you want to do is visualize directly over both the needle and the calyx of puncture. And you'll see a bullseye appearance as you visualize down the shaft of the needle as seen in this picture. Then you will switch the C-arm in the oblique plane, and then you will advance the needle until it's inside the kidney for your depth. This allows the evaluation of the depth of penetration of the needle. Very straightforward, very simple. I think the advantage is that it's easy to keep the access needle centered as you puncture directly down on the calyx and eye of the needle. But the disadvantage is that your hands are often in the field of view. You're sometimes creating a very acute angle where the needle is coming into the kidney, so it can make passage of the wire difficult, and it can also increase the risk of torque injury or pressure injury on the kidney as you're working to remove the stone. So I rarely use eye of the needle except in an upper pole access where I have minimal room to choose my skin site incision. Overall, I prefer triangulation technique. And in triangulation technique, I'm going to use the AP plane for my left and right adjustment. So in the AP plane, the C-arm is lined up with the kidney. And in this particular example, the needle is too far lateral to the calyx of puncture, which is right here. And the needle is too far medial. But in this, we have the correct alignment. So you're going to do your medial and lateral alignment in the AP view, and then you're going to rotate the C-arm to the oblique view, and you're going to do your cranial caudal adjustments in this view without changing your medial lateral adjustments. So it does require some practice and technique, but here's just a video of how I would do this. So the C-arm is lined up with the kidney, and I'm adjusting the needle medially and laterally so that it's lined up in the lower pole calyx. Once I have lined up the kidney and the needle in this calyx, I'm going to rotate the C-arm into the oblique view. And in the oblique view, without moving medial or lateral, I'm going to adjust the needle in the cranial caudal orientation. I'm then going to advance the needle in the oblique view. And as I see the kidney move, I'll do one last check in the AP view to ensure that my medial lateral alignment is still there, which you see here. And then I go back to the oblique view and advance the needle into the kidney. So this should really take, less than 1 minute of fluoro time, as long as everything goes well. And you have your correct alignments. And you can use spot fluoro, you can use pulsed and low dose to see what you need to see. Once I have the needle in, ideally you get urine pouring out when you take out the core of the needle, but that doesn't always happen. So I often will attach IV extension tubing in a 20 cc syringe. This will allow me to draw back on the syringe, and if I have no return, then I will slowly withdraw the tip of the needle under fluoroscopy, as you see here. So I'm just slowly pulling back the needle, and then as I see the fluid come out, I stop, and I know that I'm now in the calyx and can advance the wire, as you see here. If this happens, stop, do not pass go, do not proceed. This is a particular patient of mine that came in with an obstructing stone. The on-call person put a stent in, gave her antibiotics. She came back 2 weeks later. I started her PCNL case, and this is what came out. So thick, purulent material. I put in a large nephrostomy tube, and we'll bring her back a later day. This often signifies significant infection, that they weren't adequately drained with the stent. and you need to really back off and delay the case. Patients hate this, but it's the right thing to do to avoid sepsis. Also, if I'm having difficulty accessing the kidney, I have a few tricks that I'll try. If I've failed 3 attempts from one single stab incision, one skin location, I just abort that location. I'm creating a tract from the skin to the kidney, and my needle is just going to continue to go into that tract. So there's no reason to, continually puncture the kidney in that location. So I'll just make a new stab incision just a few millimeters from where I was working before, and you can often get in. You can also use continuous fluoro. I try to limit fluoroscopy to the minimal necessary, but if you're really struggling to get access, fluoroing as you rotate the C-arm is very helpful. And if all else fails, just abort that calyx, go to a different calyx, go from upper to lower, lower to upper, go to a mid calyx, whatever it takes, but don't continue to just stab the kidney in the same location over and over again. Once you know that you're in the kidney, I like to use a hydrophilic nitinol core guide wire. It's nearly frictionless, it's kink resistant, and I just place as much as possible in the collecting system. However, you need to be careful in the fact that you don't withdraw the wire through the needle, because the tip of the wire will shear off. And I've had this happen to me once before with just a piece of wire that shears off the needle. If it's in the collecting system, you can retrieve it, but if it's in the parenchyma, then you have a real issue. So just don't withdraw the wire through the needle, always advance it. And then what if the wire will not advance down the ureter? What's the next steps? So if the wire goes down the ureter, you're great, you can start dilating, but if it's just coiled in the calyx or the renal pelvis, you're going to need to use some tools to get it down the ureter. And I usually utilize an angiographic catheter, usually a 5 French Cobra or an Imager. I dilate over the glide wire with an 8 French fascial dilator, and then I make sure the catheter is very wet. So I inject saline through the core of the catheter. I wet the wire with a saline soaked gauze so that there's no friction between the wire and the catheter. And then I will just use the catheter, much like an interventional radiologist, and renegotiate that wire down the ureter. And then once it's past the UPJ, I can advance the catheter over the wire down to the bladder and exchange it out for a stiffer working wire. I always tell my trainees that you're not really in until you have a stiff working wire down. So once the glide wire is down the ureter, I feed the catheter over and exchange it for an Amplat super stiff. I like an Amplat super stiff wire because it's very easy to work over. You can use a sensor wire or some of the dual wires if that's better for you, but personally I like the super stiff. And then I'll use an 810 coaxial catheter set to place a safety wire, which is usually the sensor wire that I used at the beginning of the case to put the catheter up. You can also use an 035 removable core wire, which is very cheap. Whatever it is, make sure it's somewhat stiff, and you could use it if you needed it. But sometimes you just can't get a wire down. And I won't spend a lot of time trying to do this. If I can get a wire down the ureter, great. If not, then I will revert back to what I call the perk tick technique. I use this technique for calyceal diverticuli, and it works well if you can't get a wire down either. And what I will use is an 035 removable core J wire. And I coil as much wire as possible into the calyx. And then I will balloon dilate to just outside the kidney and then spread my way into the kidney to remove the stone. So this is what that removable core J wire looks like. As you pull back the core, this gets more and more of a loop. And so you can loop it in the calyx as you see there. I often will put a second wire in using a bright tip, much different than the 810 coaxial, but the bright tip is very short. It's actually a cordis that's utilized in interventional radiology, but I like it in these circumstances because it's very short, and so I don't have a lot of extra equipment outside the body, and it decreases the likelihood of me losing access. And this would just be an example of this. It is very harrowing when you're trying to get into the actual kidney because you're not dilating all the way in. You're just outside the calyx, and then you're going to spread into the kidney until you see stone in your epithelium. And then you can remove the stone and reset your wire down through the natural infundibulum and then readjust your sheath. So it is one of the more harrowing things that you'll do, but it will get you into the kidney when it's very difficult otherwise. Once I have the wire down, I'll balloon dilate. I like balloon dilation. The balloon itself is around 7 French. I inflate it to 18 atmospheres of pressure. I used to routinely just use a 30 French sheath. Now I use a 24 French for almost all cases, unless it's a full staghorn, then I'll use a 30. And this is just, I'm sure all of you know how to balloon dilate, but this, if not, here's how I would do this. You advance the balloon until you see the fiduciary marker just inside the calyx. Then you dilate to your 18 atmospheres of pressure and you check the entire length of the balloon to ensure there is not a waste. Then you will advance the access sheath over the balloon until the tip of the sheath is in the fiduciary marker. This particular video I don't like because they're continuing to do a 360 twist. I'll do 360 one direction, then switch back the other so that you don't get the wire tangled around the balloon. So I'll just switch back and forth as I advance. But you can see it's not a hard push. It's a gentle pressure with twisting. Occasionally, you'll see these wastes develop. Now, I think with the newer balloons, this happens less often, but you can develop these wastes down the length of the balloon, which maybe make it difficult to advance the sheath. So there's things that you can do. You can try doing Amplatz dilators. So you deflate the balloon, take it out, and then sequentially dilate with these Amplatz dilators seen here. This almost always works. However, if the scar is really dense, you can also utilize a fascial incising needle. So this needle would be advanced over the wire. It has a blade on each side. You don't want to advance it into the kidney. You only want to go down the tract because it will cause bleeding if you advance it into the parenchyma. Once you have the sheath in, then you're ready to start work. So with a standard PCNL, I'll use a standard Wolf scope. If I'm doing a 24 French PCNL, I'll use a slender scope so that I have a larger difference between access sheath size and scope size. This will allow for the lowest pressure in the kidney and the best outflow of irrigant. I usually use fragmentation and suction if I can, and I usually place a tube or place a stent, but I never go totally tubeless. Some of the disadvantages of a 30 French PCNL is that you do have increased bleeding. It has been shown that you'll have a greater drop in your hemoglobin. There's an increased risk of a blood transfusion. Some studies have showed increased pain and increased length of hospital stay using a standard PCNL. And when compared to mini PCNL, differences have been identified. Mini PCNL has been found to have comparable outcomes to standard PCNL with reduced bleeding risk. So a randomized prospective trial comparing mini PCNL to standard PCNL found that the mini PCNL patients had stone burden that was similar to the standard PCNL, but their stone-free rate was 75% versus 72%, which was great, but their hemoglobin drop was significantly less at 0.7 versus 1.4, and they were more likely to perform the case tubeless, so place a stent versus a nephrostomy tube, 21.1% versus 2.8%. Another retrospective study that compared mini PCNL to standard PCNL found that the stone-free rates were again very similar, 86 to 90%. There was a lower blood transfusion rate in the mini PCNL, which has also been found in other studies. And the complication rate was lower in the mini PCNL with a shorter hospitalization time and more likely to perform tubeless. I have to say that in my hands, I do quite a bit mini PCNL, but I don't feel the stone-free rate is as good as when I use a 24 French sheath or a 30 French sheath. I feel like I'm not able to look around with a flexible scope at the end as well, because you have to use a ureteroscope, and then I might be missing very tiny fragments. All my patients get a CT scan afterwards, so maybe I'm being hypercritical and I'm finding little fragments that would make no difference anyway. But in my hands, I'm not as good at rendering the patient stone-free with a mini PCNL as I am with the standard. So the overall advantages across the globe for mini PCNL is that it can be performed tubeless, although I do standard PCNL tubeless. Mini PCNL can be performed as an ambulatory procedure, although I do standard PCNL as an ambulatory procedure. Ambulatory mini PCNL is a cost savings, around $984 per case, and a mini PCNL can be performed totally tubeless, without any stent or anything left behind. So definitely some advantages. But what are the advantages of standard PCNL? And just to redefine the nomenclature, a 24 French or a 30 French sheath is considered standard PCNL, although I think there's significant differences between a 30 and a 24 French sheath. I think the standard PCNL is ideal for complex stones. You're rendering patients stone-free through a single access in these cases oftentimes. And it's really dependent on the ability to use the larger lithotrite with the better suction. When you use a standard PCNL, the access point can be away from the stone, and you can use a flexible scope to remove the stone. That's very difficult to do with a mini PCNL. It's also faster. It also decreases the intrarenal pressure. And this is just a patient where I would probably do a standard 24 French PCNL, because I'm probably going to get access more anteriorly, or I'm sorry, more superiorly, like in an upper pole calyx, and come down and work on this because the stone is all in an anterior calyx. But let's go back to this pressure concept. We know that the pressure inside the kidney increases as you decrease the access sheath size. And this increase in pressure and irrigation pressure can potentially increase the risk of sepsis. This particular study looked at 843 patients who underwent mini PCNL with a history of preoperative UTIs. Sepsis in the cohort was associated with the size of the channel or the access sheath, the OR time, and if there was any tear or damage to the collecting system, so a poor access. And what's interesting is as they got to 22 French, none of the patients had sepsis. At 20 French, they had 1.2% sepsis rate, but when they got down to 16 French, the sepsis rate was 9.8%. So clearly it linearly increased as you decrease the access sheath size. So I do think there is something to this concept of pressure, and that as you get smaller and smaller, you're increasing the pressure. So you really need to think about that in these infected patients. But again, back to the standard access or a standard PCNL, I think it's ideal for complex stones. This is a particular patient of mine who's a 32-year-old woman who has spina bifida. She has recurrent multi-drug resistant UTIs, and she's had an ileal conduit. She has a functional solitary kidney with struvite stone disease, and you can see that this kidney is down in the pelvis. So in order to get these stones out, I have one access point through the buttocks, and I can remove this stone, but to get to this stone requires the use of a flexible scope. And this is a standard PCNL case. This is a long tract. We're going to be changing back and forth between instruments, and mini PCNL, there's just no access point for this upper stone. But it's also ideal if you're looking at full staghorn calculi. So this is we did recently publish our series on rendering patients stone-free through a primary single access site when they have full staghorns, and this is just a particular patient. So we put in an upper pole access. Here's the pre-op scout versus the post-op CT. You can see the large staghorn there. And then this is just the post-op CT scan. You can see that this patient is completely stone-free through a single access in the upper pole. and 1 trip to the operating room. I wouldn't say they all go this way, but when they do, it's because we've utilized a larger sheath so that we can work through this one access and minimize multiple percutaneous access points. So regardless of if you're using 24, 30, or 16 French, the main take home is with the rigid scope, you want to utilize gravity irrigation to minimize pressure in the kidney, and you want to limit torque. So if you're really torquing down on that scope and causing some pressure on the parenchyma, then you want to switch to a flexible scope. You want to also limit how much you're using the lithotrite, whether it be a Trilogy or a shock pulse or a ballistic device. You want to limit the use of that near the ureteral pelvic junction, because this again is the thinnest area in the collecting system and is most likely to get injured. And then I utilize intermittent suction for poor visualization. So you just come on and off the suction. I might take it off the pump even and have my assistant do the hand control of the irrigation if I'm having a hard time seeing. Once I've debulked the stone with the rigid lithotrite, I will do flexible nephroscopy. I do this in every single case. I feel like it decreases the need for additional treatment. It allows me to limit access tracts. And if I find a stone, then I will do laser lithotripsy or basket extraction. So by utilizing contrast through the scope, I am using fluoroscopy and a visual inspection to ensure that I see every area of this kidney and have ensured that there's no residual fragments or anything left of concern. It only takes 1 to 2 minutes at the end. This particular case is rather complex, so it took a little more manipulation to see the different areas. As you can see, there's a large upper pole area, but in the end, this patient was stone-free. But what about the morbidly obese? I know all of us are seeing more and more of these patients. Actually, I see them so often, I kind of feel more comfortable with an obese patient than a thin patient these days. But you are limited in what you can do with the obese patients. So shockwave lithotripsy has limited use in these cases. Ureteroscopy works very well as long as they have small stones, but sometimes they don't, and you need to do PCNL. They have common comorbidities that increase the risk of stone formation, like hypertension, diabetes, gluttonous food intake. So they have increased excretion of calcium oxalate, sodium, and uric acid. And this is a particular image from Dr. Segura when I was a resident with him, and I think it's a pretty famous image. It's made it into a lot of talks. So I put it there as a homage to him. But anesthesia in the prone position used to be a big concern prior to COVID. Then with COVID, they actually put a lot of the ventilator patients in the prone position, so nobody seems to be as concerned anymore. But the original concerns were really total lung and functional residual capacity is reduced in the prone position, and you can have compression of the IVC, which will reduce your preload and oxygenation. So you can do these patients in a lateral or a supine position. I do feel that it increases the skin to stone distance, so it can make it even more difficult. I have seen anesthesia use conscious sedation and local anesthetic for obese patients. They might have an awake intubation and then have the patient assistant positioning themselves prone. All of these tactics have been tried and utilized. Once you can get the obese patient positioned, you may have to use an extra long access sheath. So they do make a 20 centimeter access sheath. The problem is that the balloon is not 20 centimeters. So you have to balloon dilate half the tract, advance the sheath halfway, reset the balloon, and then dilate the rest of the tract. Because when you balloon dilate, you want to make sure at least part of the balloon is out of the skin, so that you can at least start the sheath being advanced. So you need to utilize this double dilation technique. Other things you can try is you can try a skin cut down. So make a very large skin incision and then use a retractor to retract the skin out and fat out of the way and then start your access at the fascia. Another technique is get into the kidney, put a large reentry Mallinckrodt nephrostomy tube in, and wait 2 weeks. The tract will shorten naturally, and you will be able to get your sheaths in more easily after the tract shortens this way. So I've utilized all these techniques. I like the extra long access sheath. The problem is your nephroscope is limited with the sheath, and you're often using a flexible scope with laser lithotripsy. I will say that the largest patient I've ever done a PCNL on was 800 pounds. And we had to utilize all 3 of these techniques to do the PCNL, but she did fine. So what about bleeding? I think bleeding is probably one of our most feared complications in PCNL. We understand that sepsis is life-threatening, but we know how to handle that. But bleeding can be quite disturbing when it occurs. So there's a few troubleshooting tips that I have. Your sheath may be too shallow, and you might be having some of your bleeding from the parenchyma. If it looks, when you look in with the scope, that you are too shallow, you can definitely see urothelium beyond where you are, and you have quite a bit of bleeding at the edges of your sheath. Then I will take out the scope, reinsert the balloon, redilate, and advance the sheath. You can't, if it's just a small distance, you can try to re-advance the sheath over the nephroscope, but that doesn't always work. So the safest thing is to just reinsert the balloon, dilate, and then advance the sheath, and that should take care of the parenchymal bleeding. Sometimes you're bleeding because you're too deep. So you've advanced the sheath too far, and you have a tear in the infundibulum. If this is the case, and you can obviously see this when you put the scope in, then it often will lessen as the case progresses. The oozing will stop. It's a venous ooze. However, if you see no improvement in 5 to 10 minutes, it's best to just abort, put in a nephrostomy tube, and come back on a different day. Sometimes you'll see bleeding from what we call chronic infection or just a generalized ooze. Even patients that are anticoagulated, I don't do PCNL on actively anticoagulated patients, but patients who have previously been anticoagulated and stopped, they still seem to bleed a little more than someone who hasn't. And this is just something you have to deal with in the case. You have to work fast, get as much done as you can, and then stop. However, if you see pulsatile bleeding, this is an arterial injury, and you really need to just stop the case. Pulsatile bleeding is going to result in significant amount of blood loss. So you can either reinsert the balloon that you use to dilate the tract, and this will tamponade the artery, or you can put in like a K-tamponade balloon. The difference between your balloon dilator and a K-tamponade balloon is that with the K-tamponade balloon, you can actually drain the kidney. It has holes within the catheter so that it can drain the kidney as well as tamponade the tract. But hopefully you don't get into one of those situations, and you can complete the case and then think about your exit strategies. So when I was training, this is what it looked like. We put in a big 22 French balloon. We put a stiff angiocatheter down the ureter so that we would have access to the kidney and ureter, and this is what the patient woke up with. And I don't do that anymore. So if I'm going to put in a nephrostomy tube, I utilize a small 10 French cope loop, and I like that because it is more comfortable for the patient, and you can hide it cosmetically in a tattoo, say, like this particular patient. This actual patient, I wish I had the follow-up image from when they came back to clinic, but you couldn't tell that they ever had a PCNL performed. And why do I use the smaller tubes? Well, there have been studies that indicate that the smaller tubes have less discomfort. They don't seem to influence the hemorrhage rate. The patient's going to bleed with a big tube or a small tube. The only problem is that if you use a small tube in a case where it's bleeding a lot, it can occlude and clot, and then you have some obstruction to that kidney, so you have to think about that. In the CROWS database, they compared large and small tubes and found that the large tubes had less bleeding and less complications, but that's the only study that I've identified that actually found that. In general, this is what I've always done. Now, I'd have to say in the last year, I've moved towards putting more stents in. With COVID, we've had to transition to outpatient PCNL for a lot of cases. I mean, they would let me operate, but I had to ensure that my patients would go home. So I moved away from nephrostomy tubes, and I would say probably 60% of the time I just place a single double J stent in the ureter and then close the skin tract. Patients will go home the same day and do quite well. But if I have a patient that needs to spend the night, multiple comorbidities, comes from a long distance, this is what I will plan to do. And then on postoperative day 1, I will get a non-contrast CT scan. If there are no residual fragments, then I will remove the tube on postoperative day 1. If there is any residual fragments, then I will take them back for a secondary percutaneous nephrolithotomy or ureteroscopy. Sometimes you can do the secondary under sedation if it's a small little fragment, and then discharge them home the same day. All of my patients used to get a nephrostogram, but I stopped doing that, and now I just do the methylene blue test. So I inject 7 cc's of methylene blue into the nephrostomy tube and then cap it. Within minutes, you should see the methylene blue in the Foley, or the patient should urinate it out if you've already removed the Foley. And that tells you that the ureter is open. When this has been studied, there's been no difference in predicting obstruction between using methylene blue and a nephrostogram. And this was published by Truesdale in 2016. So it actually saves a lot of fuss for the patient. They don't have to go down to the x-ray suite. You can do it right in the room, and it can be determined very quickly. But I only do this in the non-complicated cases. If you have a complicated case where you're worried about renal pelvis injury or ureteral injury, and you don't, or if you don't know the tube is in place, then you definitely don't want to utilize the methylene blue. For the last part of the talk, I wanted to briefly discuss ultrasound-guided access. It is the newest rage in the United States and across the globe. A lot of people are utilizing ultrasound. I use ultrasound not as often as I probably should. I use it for the more complex cases, cases where I can't get a catheter up, or maybe a really thin patient. I'll utilize ultrasound-guided access. And there are several benefits to it. It is found to decrease radiation exposure. One prospective cohort looked at 100 patients, and they had a decrease in fluoroscopy time using ultrasound and a decrease in radiation exposure. You have real-time visualization to the surrounding organs, such as the bowel and the pleura. This study looked at 184 patients who underwent PCNL and found that there was no organ injuries in the ultrasound group, but there was one pneumo in the fluoro group. So there may be a safety benefit to ultrasound. And they feel like ultrasound is actually easier to learn for the surgeon as opposed to fluoroscopy. When you set up for ultrasound, you want the patient to be in the supine position. If you're going to do supine, usually a modified Valdivia position, as you see here with the patient in stirrups and the flank up, just like what you would do fluoroscopically. And you want to mark out your 11th and 12th ribs, as well as the iliac crest and the paraspinous muscles, so that you know the area that you're looking at. It's important to know the mid-axillary line as well, because you don't want to go anterior to this, just like what you would do if you're doing fluoroscopy. When you do percutaneous access, you're going to rotate the probe 30 degrees to be parallel to the 11th and 12th rib. You're going to use a longitudinal view of the ultrasound probe to keep the needle in view at all times. And then urine drainage from the needle confirms placement. A lot of times people will put up a 5 French catheter, just like you do with fluoroscopy, and instill saline to make the kidney hydronephrotic and have a pressure in there so that you will get fluid return when you advance the needle. Use a non-hydrophilic wire. This is different from fluoroscopy. So most people will use like a removable cord J wire because it's very hyperechoic, and so you can see it well on the ultrasound. If you're going to dilate the tract using ultrasound, you're going to advance a 10 French dilator over the wire, and you'll see that the signal from the wire disappears, and you know that the catheter is over that. And then you're going to advance the 24 French balloon next over the wire, and then you can dilate under vision. All of this is very similar to fluoroscopy. You're just guessing a little bit more as to where things are. It's just not as crisp and as straightforward. If you're thinking of incorporating ultrasound guided access into your practice, you want to look at patients with lower BMIs. As patients get more and more obese, it becomes very difficult to get a good ultrasound image. Factors associated with success of ultrasound guided access is hydronephrosis, kidneys more hydronephrotic, much easier to see, much easier to perform access. If the kidney has a staghorn calculi, it's actually quite difficult to see, and it's difficult to get the wire in and perform the access, so maybe avoid those initially. When we looked at outcomes of ultrasound-guided PCNL, a meta-analysis of 8 studies comparing ultrasound versus fluoroscopy looked at over 900 patients and found that there was a favorable safety profile with ultrasound-guided access over fluoroscopy, and that there was no difference in stone-free rates. When you look at cost comparison, ultrasound-guided PCNL has a shorter OR time in these particular studies, with a 30% cost savings basically from the shorter OR time. Also, ultrasound-guided PCNL has a shorter learning curve. So the learning curve for ultrasound-guided PCNL is around 20 cases. Looking at fluoroscopically guided PCNL, it's around 50 cases to feel very comfortable with it. So it is shorter, and the amount of time and radiation exposure per case decreases significantly as you do more cases over the 20 case mark. So you get better and better if you just stick with it, basically. The key concepts are really frequency. So that's the cycles per second of a signal being emitted. A higher frequency leads to a superficial penetration. A lower frequency is a deeper penetration. So you want to use around 3 to 6 megahertz for a kidney. You can adjust the depth, the focus, gain, and time to make the image clearer. And this is just a video. I'm not going to run through the whole video because it's quite long. But this is from one of the courses done with Roger Sir and Tom Shee, where we do hands-on ultrasound guided access. So this is a patient in the prone position. You can see the paraspinous muscles there, and they're finding the iliac crest and the ribs. And you're going to place the probe just parallel to the paraspinous muscles and then fan the probe back and forth to identify the kidney. You can see that there's a shadow from the rib. This is just what you have to deal with when working with the kidneys. And once you identify the kidney, you want to see where it is in relationship to the rib and any surrounding structures. So he's scanning to see if there's any organs between the kidney and the skin up here. Okay, so once you identify that, then you are going to rotate the probe to get the rib shadow out of the way. So he's going to rotate the probe 30 degrees. I'm just going to advance this just a little. And he's planning out his tract here. So you can use, here's the 30-degree turn here. So you want to, I like to use the law of 30. The probe is 30 degrees off the midline, and my needle is going to come in at a 30-degree angle into the kidney. And now he has put the needle access guide on his image, so he knows where the needle is going to go in through the needle access guide. And then in that 30-degree image, he's going to identify the calyx he wants to puncture in the kidney, and then line up the needle guide to that calyx. If you see the stone, you're going to see a white edge and a dark area behind it. So this is the stone with the papilla behind it. And then you're going to advance the needle through your needle guide into the calyx, as you see here behind the stone. And you can see the needle advancing into that calyx, and you can see the kidney move. This is PCNL access with a needle guide. Freehanding it is much more difficult than this, but it's still all the same concept. And I would say if you're starting out to get ultrasound guided access, utilize the needle guide and have fluoroscopy available to check your results at the end. Once you have your access in, you can then advance your wire under fluoroscopy to see that you're in. And you can choose to do the dilation either ultrasound guided or fluoroscopically, as seen here. So we've covered a lot today, from access to stone removal to exit. We've covered fluoroscopy, we've covered mini-perc, we've covered ultrasound guided access, but overall, I think PCNL for large complex stones can result in excellent outcomes with minimal morbidity if you're conscientious and take your time planning out the case. You want to adjust to the situation. Go to the stone and adjust to the patient. Don't try to make them fit into one treatment mode. Triangulation and eye of the needle are two common techniques utilized, and they both have their place. I utilize perc tick technique where you don't get a wire down the ureter when you have a tight situation or a diverticulum, and this can be very helpful for difficult stones. Mini PCNL and ultrasound guidance are newer beneficial techniques that you can incorporate into your practice and utilize them where you see fit. So thank you very much for allowing me to speak this morning, or I guess this afternoon for you, and I'm happy to take any questions that you might have.
Amy, thank you so much. It's an absolute masterclass, and it sounds like you're suffering from the same cold-like symptoms that's ripping through our department at the moment. So
Yes.
Really, thank you. I know it's really early in the morning there. I was reassured by hearing other people talk that what I'm doing is still in date and not old-fashioned. And I love this concept of putting the ureteric catheter up on the trolley, avoiding yet another move of the patient. I remember doing that as a junior resident when PCNLs were still done in interventional radiology. And it was my job to put the ureteric catheter up, and that was all I was allowed to do. But I still do them prone. It's nice to see you do lots of prone PCNL. I might change over to that. One question for you. I'm quite interested in medical legal urology and giving opinions for patients when things go wrong. Is how you do a North American consent for a PCNL. What sort of depth do you go into in terms of complications?
That's great. I have a standard talk that I give all my patients, and I want to make sure they understand 4 concepts. One is you may have a residual fragment that will require second procedure, that it's not a guaranteed stone free. This may require another trip to the OR to get any residual fragments out. 2, I always talk about bleeding. I say that bleeding is not a common complication, but it can occur and it can be life-threatening. It could require a return to the operating room for coil embolization. That is unlikely to happen, but it can happen, and I need to tell you about that. And then 3, we talk about sepsis. So sepsis occurs, 1 to 5% of the time, depending on the patient population. I talk about how we check a urine culture before surgery. We give antibiotics before, during, and after the surgery, but there's no guarantee that you won't get sepsis, and this again can be life-threatening. And then I talk about injury to surrounding organs, the lung, the liver, the colon, the spleen. All of that can occur. It occurs less than 1% of the time, but it can happen. And that's the talk that I give the patients.
Thank you. Tubeless PCNL, I can remember publishing on tubeless PCNL probably early mid 2000s, when I was probably a bit more aggressive and a bit more gung-ho and less experienced than I am now. Do you think it's really fallen from favour completely tubeless PCNL? 'Cause like you, I think we've moved over pretty much to stenting people to reduce pain and get them out of hospital faster.
Yeah, I mean, I was so hesitant to adopt stenting because with a ureteroscopy, patients hate stents, right?
Yeah.
Like they're miserable, but they seem to not have that issue after PCNL. They seem to do extremely well with a stent after PCNL, and I'm beginning to think this is more of a pressure issue and less of a stent issue. That's a whole other talk. totally tubeless, like nothing left behind, to me just seems very cavalier. Like, we know there's going to be bleeding. We know there's probably going to be a blood clot up there. There could be a residual fragment. There is swelling. Like, there's swelling that occurs from manipulating the inside of the kidney. So I don't think I will ever switch to totally tubeless, but I do like stenting. I think patients do better with stenting than they do with a nephrostomy tube.
One more is your approach to anticoagulation. So Zaf, my colleague, who's also an endourologist, we debated this last week on, do you give Clexane or heparin that night if it's been a morning operation? I never have. Once it was given in error by a junior doctor, and the patient got a huge hematoma that night, which burnt me. And we usually try and have them out of hospital the next day anyway. But for the non-anticoagulated patient pre-op, if they were going to stay a night in hospital, would you give them anticoagulation that night?
Generally not, no. I mean, I tried to get them up and walking and moving, so I feel like, heparin prophylaxis is probably not that important. I always find it interesting that we want to give heparin prophylaxis to our spinal cord injured patients when they're in the hospital, because they're not any less mobile than what they were before, right? But we are very active and try to get them moving. Anticoagulation is so difficult. I will continue aspirin. Like, I have no problems with aspirin doing PCNL. I usually like to assess the color of the urine before starting any bridging heparin. So I make them wait at least 24 hours before we start bridging, if they're on warfarin or Coumadin.
And for this, most of them are just atrial fibrillation on NOAC or warfarin. Do you give them a week before restarting, or yeah?
Yes, if it's just atrial fibrillation, I'm very comfortable in waiting a week.
Yeah.
Where it gets a little more difficult is if they have like an artificial mechanical valve, or they've had multiple DVTs or thromboembolic events, then we have a more difficult scenario.
Thank you. I love your blue dye technique. Like you, we don't do many nephrostograms. We do RCT on day one. But getting down into radiology, into interventional radiology, when there's a list as long as your arm of biopsies and nephrostograms to do, we might just look at adopting that. It's so simple and so nice. Thank you again. Zaf, have you got any?
Yes, well, thanks very much, Emmy. It's fantastic talk. I mean, there's so much detail there and so much stuff in there. I don't know where to begin, but I'll try and keep it brief. And I also really like the Truesdale idea. I'm definitely going to put that one into practice. One question I wanted to ask was about maxi PCNL, if you like. And you mentioned that you've gone down from a 30 French implants down to a 24 French sheath, and I wondered whether or not there was any compromises you had to make there in terms of the instruments that you're using, through the scope or the scope itself, and so on.
Yes, so so if I have a full staghorn, I'm probably still going to do a maxi perk at 30 French. And the reason is that I can use different instruments. So I can use the largest trilogy probe, which is going to last longer while I'm breaking up that stone. When I go down to 24 French, I use a scope called a slender scope. It's from Storz, and it will fit easily between the 24 French and the scope, but I have to go down one size on the trilogy probe. And I can say just decreasing down one size on the trilogy probe, it'll break more often, and the suction is not as good. So, I'm always torn, because you can use smaller and smaller trilogy probes for like mini PCNL, but they break so frequently and the suction is so poor that I think if you have a large stone burden, you're better off just using a larger sheath and using bigger instruments to get that out.
Brilliant. Thanks very much. And perhaps in a similar vein, I was just wondering, prone is obviously your preference. Are there any cases where you wished suddenly that you did have the flexibility to have a retrograde flexible uteroscope in there, or is it down to sort of good preoperative planning and the flexible nephroscopy? Or
yeah, so if I have a case where there's like a small stone in a mid calyx, right? Like, so you usually have like a large stone in a lower pole or an upper pole calyx, and then there's some pesky little small stone in a mid calyx. That's when I actually like to have access from below, because it's hard to make a turn from like a lower pole. You remove the big stone in the lower pole. Now you've got to make a turn with a flexible scope to try to get a mid calyx, and that can be a tight turn. So sometimes I will use like an ESERS technique, not for access, but to get that mid calyx stone easily in the one setting. So I'll use a supine setup and then have access from below.
Thank you. We've got one last question, if I could, from one of our faculty, Tommy, who's a endourologist from the South Coast, who's joining us virtually. Hi, Tommy. Hopefully you can speak. I don't know if you're on mute or not. You may be. Yeah, I can hear you now. Thank you. Far away.
Hi there. Thank you for an excellent talk, Dr. Cranbeck. I really enjoyed it. I'm interested in ultrasound access for PCNL, as we do in UHD in the UK. And one thing that we don't have in our curriculum is a training of ultrasound. And I'm just wondering, in the American curriculum, do you have a training program, or do they learn it just in theatre? Do they have to do a certain amount of scans of kidneys and so forth? Because it's something that's lacking in our program, but I just like to hear what happens with you guys.
We do not have anything that is formalized for the training program for ultrasound guided access. It's still the minority of surgeons that are using it. I learned it by spending a week with Tom Chi. So he was gracious enough to let me come watch in his OR. And, you know, he did maybe 10 perks over the course of the week, and I was able to see his technique and learn how to do it and bring it home. There's multiple courses at the AUA that you can utilize to learn ultrasound guided technique, as well as the World Congress. The nice thing about ultrasound is for me, it was hard no matter how much I tried outside the body versus in the OR, because visualization is the key, right? If you can learn how to find the kidney and understand what you're seeing, that's the whole difficulty with ultrasound. So what we've encouraged people to do is to utilize the ultrasound in the clinic. Like if you have time with your patients, just ultrasound, you know, as many stone patients as you can. Just quickly look at the kidney, get used to finding the kidney and understanding the anatomy. And once you can find the kidney and understand the anatomy, the rest of it's very simple.
Yeah. The new handheld ultrasounds are very good that plug into the iPhones for that particular skill learning. The second question to have for you, over the last few years, I think I put in one nephrostomy in my PCNL, the rest have been stent only. How long do you keep the stent in for?
So if it's really straightforward and all, you know, the ureter was large, I could run the scope down the length of the ureter. I'm not concerned about residual fragments. I'll actually leave the stent in on a dangle extraction string so the patient can remove it themselves. Usually have them wait 3 days and then remove the stent. If it's at all tight, or I'm concerned about bleeding or any residual fragments, we wait a week and then they have their CT scan before I remove the stent in the office.
And what's your go-to stent? What size do you put down or put up even? I presume you put all your stents retrogradely then, do you, when you've got a dangly string?
I actually put them antegrade. I will advance a basket up the 5 French open-ended. I grab it and pull it out the sheath, then I tie the dangle extraction string to the basket, and then I pull everything down and through. So it's kind of a funny little way of doing it, but I do it antegrade. I usually use a 6 by whatever centimeter stent, 6 French by, you know, whatever centimeter the patient is based on their height.
Okay, great. Thank you very much.
Thank
really
you.
Amy, I know you've got to operate today, and it's still very early in the morning. So thank you so much. It was an absolute masterclass. It's really, really kind of you, and thank you to Boston Scientific as well for facilitating you talking to us. We really enjoyed it, and I've learned a lot. And I hope you have a good day operating.
Well, thank you so much for having me, and you guys have a great day. Bye.
Thank you.
Yes, thank you.
Goodbye. I think what we'll probably do is break now for a very early lunch. We've changed our schedule a bit to get afternoon speakers in the morning. So I think we'll regroup at 1 o'clock if everyone has some lunch. There are some adverts that Boston Scientific and Wolf will play on a loop over lunch. We'll start in the afternoon at 1 o'clock with what we call our Stone Committee. Not quite MDT because we don't have a radiologist or a microbiologist, but we'll talk through the common problems that we all face every day. So do grab some lunch or a cup of coffee, and we'll see you back at 1 o'clock. Thank you.